Greetings from Indian Medical Association. Greetings from Indian Medical Association, our digital IMA initiative in association with IMATV and Libraries. I am Dr. K.T. Agarwal, Honorary Secretary General. Welcome to our weekly show every Thursday 3 to 4 p.m. where we discuss one particular subject. We just had a liver day and we thought of discussing liver disorders, talking about prevention, early diagnosis of liver disorders. And today in this discussion, me and my colleague Dr. V.K. Monga, who is here as the Dean of IMACGB, we will be and along with Dr. R.M. Tandon, our Finance Secretary, we will be interacting with two experts, Dr. Ajay Kumar, Assistant Professor of Gastroenterology at GV Pant Hospital, and Dr. Anand Vasudeva, who is a pediatrician in East Delhi and who has been a Joint Secretary of Indian Academy of Pediatrics. And so we will be covering liver both in adults as well as in children. First of all, I would like to know, Ajay, as a cardiologist and as a physician, we are seeing an epidemic of fatty liver. And this fatty liver is associated with coronary artery disease. In gynae, it is associated with PCOD. In gastroenterology, it is associated with fatty liver. For neurology, it is associated with, we have a stroke which is occurring because of that. And with gynecologists, they are again even in postmenopausal dysfunction because of this fatty liver. Why this epidemic in India?
First of all, I'd like to thank IMA for inviting me. Sir, actually, what I think is change in lifestyles should blame for this. Plus, some component of genetics is also involved. Because what we are seeing in our OPDs day-to-day practice, that two of the patients were coming to us. One were overweight, and the reason for being them is sedentary lifestyles. Nowadays, exercise is out of bound for most of the people, and the majority of the people are taking food which is richly fat. And other thing is genetic factor. Unfortunately, that has not been explored in this part of the world. But studies from West has in fact shown that even at the lower BMIs, Indian patients do get a fatty liver. So both of these factors has to be blamed for this increasing epidemic of fatty liver disease. And as sir, you are well aware regarding this diabetes. In fact, we are going to take over China as one of the leading diabetic population in recent time only. So keeping all these things in mind, diet, environmental and genetic factors, these things to be explored further.
What is the incidence of diabetes, this fatty liver in children? Because there are many surveys which has come that says 37 to 38% of the children are obese and they may be having fatty liver.
In fact, obesity is becoming quite a menace in pediatric age group also, in children also. And as you have quoted the figures, we also had a study done in most of these elite schools in Delhi, and we found that almost 40% of these children are obese. And apart from that, a lot of almost 12% were having even hypertension. And 5% of these were needing actually medication for hypertension. But it was very difficult to convince parents that this is all because of lifestyle and sedentary lifestyle and bad eating habits.
So, Dr. Monga, when we talk about fatty liver, we did discuss it in one of our sessions, and I'm going to repeat that fatty liver is a recent phenomenon. Probably it was not there in our Vedic era. Probably. Because we don't have any evidence of heart attacks occurring at that particular time. Except for Raja Dasharath, we don't have any evidence that leaders used to have heart attack. But in today's leader, you will see that at least 10 to 15% of the ministers either have done angioplasty or surgery. That means they were their leaders, they are our leaders in that. He says normal weight obesity, that means normal weight and yet you have abdominal obesity. I want to narrate one thing. I'm reading one of my articles which I wrote. And I said that except that Lord Ganesha and Kuber, both of them had obesity. They had pot belly obesity, but there is no evidence that they did suffer from diabetes. Okay, so I'm just reading one sutra written in other Vedic literature. Gajananam bhut ganadi sevitam kapit jambu falsara bhishitam उमा सूतम शोक विनाश करणम नमामि विघ्नेश्वर पदा पंकजम. Now let me analyze it. Gajananam, O elephant face, worshipped by everybody. That means they are talking about Gajananam means Ganesha. Bhuta. Bhuta, what does Bhuta means? Anything which is offered to you. What is offered to you is Durva grass and Bilva Patra. Belpatra. We do Ganesh Puja with Durva grass. Durva grass is bitter grass. We have three grass. The Kusha grass, Durva grass and wheat grass, and they are bitter. And they say, we worship you with Belpatra. That means Belpatra. He says, Gajananam, what was that? Gajananam Bhut Ganadi. Ganadi means equal quantity. Sevitam, sevan karna. So they says, you take whatever is offered to God in equal quantity, you consume. So Gajananam Bhut Ganadi Sevitam. Kapit Jambu Falsara Bhakshitam. Bhakshitam means eating. Falsara means fal, the fruit. Jambu means jamun. And Kapithu means ketfal, which is the elephant apple, which is available. So you have four things. If you do that, if you take in equal quantity, bel patra, durva grass, and eat jambu, jamun, and ketfal, Uma Sutam Shok Vishana Karnam. Uma Sutam. Uma means meetha. Sutam means पैदा उसका पुत्र. मीठे से होने वाली उमा सूतम शोक बीमारियां विनाश करनम. उसका विनाश करता है. नमामि विघ्नेश्वर पदा पंकजम. ऐसे गॉड को जो हमारे दुखों को निकाल रहा है उसको हम नमस्कार करते हैं. So this prescription probably was a preventive prescription written in our Vedic literature for diabetes or for metabolic cirrhosis. This is this is not mine. This is not mine. I'm only trying to find out this particular thing. That means our Rishi Muni knew that Indians are prone to get fatty liver, they are prone to get insulin resistance, they are prone to get hyperinsulinemia, they are prone to get diabetes, but they never had it. And today in cardiology we know that abdominal circumference is the only parameter. If you don't want to spend money, just check the abdominal circumference, and if the abdominal circumference is more than 90 cm in men, 80 cm in women, we have associated fatty liver. And we have now come out with a sutra that keep your blood sugar lower than your abdominal circumference. That means if your abdominal circumference is 110, your fasting sugar should be lower than 110 and try to bring it to 90 and 80.
Ideal would be 90 and 80.
No, I said if your abdominal circumference is 110, so first of all is try to bring your sugar less than 110 and then aim it at 90.
Both.
Slogan is whatever is your abdominal circumference, your fasting sugar should be lower than that. So for general public it becomes like a simple formula. With that. So if you prevent fatty liver, you will also prevent diabetes. You will prevent hypertension. You will prevent CKD. So Ajay, what I now want is what is fatty liver, what is NAFLD, what is NASH, non-alcoholic steatohepatitis, what are the stages, how do I clinically diagnose them, the different types of fatty. Today, suppose a person comes to me, I check his abdominal circumference and I find it's more than 90. So I presume that he has a fatty liver. Do I go for SGOT, SGPT? Do I go for ultrasound? Do I go for a biopsy? What do I do? And then?
To diagnose fatty liver, the ultrasound is first line of investigation. And in ultrasound, we categorize the fat in grades 1, 2, and 3. The grade 1 is when the liver becomes hyperactive. Grade 2 is when we are not able to see the fatty liver clearly. And grade 3 is when normally when you ultrasound, you can see the daffodil shadow which will not be seen. So normally these 3 grades are reported.
So how do I say hyperliquid? Do I compare
you have to compare spleen or kidney.
Spleen or kidney.
Normally kidneys, people say kidneys, but some studies have shown even spleen can also be used.
So I have to see the echo density of liver with the kidney, and if it is more than that, then it is grade 1.
Grade 1.
And if I cannot see hepatic veins,
It's grade 2, sir.
that means hepatic veins and the whiteness is getting mixed, it is grade 2. And if I cannot delineate the diaphragm,
It's grade 3.
it is grade 3. Okay. Then if I have, say, grade 1, what do I do?
Grade, actually then we have...
My second question is everybody trained in diagnosing fatty liver? Or do you require, because this is a recent phenomenon, is everybody trained? Is every personality, whether MBBS or MD?
Actually, the majority of the radiologists told him if they have an MD, then usually in recent years they train.
No, I'm talking about 80% of
Most
us.
of the guide the size of
Majority people, sir, actually unfortunately still if we see, majority of people they just said fat liver, nobody is aware of this grading. So then one thing is that we have to train for this grading. We have just said enlarged liver, plus some hyper, but they would not tell the
Okay,
fat
so
liver.
it is important to know grade 1, grade 2, grade 3. So the message is very clear that if you are sending the patient for ultrasound, and if he writes fatty liver, send him back and tell him to write down grade 1, grade 2, and grade 3. Okay, so one message we have learned today is that don't accept the diagnosis as fatty liver, let it come back as grade 1, grade 2, grade 3.
And the
Now
next,
grade 1.
the next thing is that when we look at all other things like whether he has got impaired tolerance, diabetes, hypertension, and dyslipidemia, and what are his liver enzymes. Because now the next question of whether it is simple fat liver is a NASH or cirrhosis. So unfortunately we don't have any biomarkers or
So even with a grade 1 fatty liver, it can be NASH.
it can be NASH.
Okay.
But more the fat, more chance of NASH will be there. So other things like suppose you got people have devised simple figures like bar score, like how much is the BMI, whether it is still raised or the hyperthyroidism is there. So more the number of factors, more chance NASH will be there. Somebody who got only 1, chance of NASH like only 5%. Suppose you got high or you got obesity and your TG is also high, so it will be like 30%. So people have devised simple scores just to avoid a biopsy to find whether NASH is there or not. So this scores sometimes may be helpful, but ultimately the gold standard for diagnosing NASH is still biopsy as of now.
So grade 1, do I have to do biopsy or I need to grade 2?
So actually we have to look all this profile together in this. Suppose somebody has got normal liver enzymes, then biopsy may not be advisable. And somebody who has got like raised enzymes and if they are not coming down despite...
I don't want to use terms. When you say raised liver enzymes, what is the definition?
If
Normal
there is,
is...
sir, more than upper normal, but as of now, sir.
No. Suppose it's normal is 18. When it becomes 40, it becomes 7.
Sir,
I
actually,
can call it as upper normal.
so for what actually recently people have told take 18 as for the females and 30 for the males. Previously it was like 40 and 40 for labs, but now the people are telling just take 18 for the females and 30 for the males.
30?
30 for the males.
Not 24.
Not some studies. 30.
Because we are taking it as average, we are taking it as 20 plus minus 4. You can say 16 to 24, 25. If it is more than 20, if it is 40, for me it is twice normal.
Normal.
If it is twice normal, I am worried in a person with a fatty liver.
And then the possibility of NASH can be there, but performance for biopsy is very crucial. Majority of the patient don't want. What we offer to this patient as our practice that we are some diet exercise for like 6 months.
I'm coming for prevention, but what about at this particular stage? Can I go sign in for a fibroscan scan?
Fibroscan can be done. People have tried in this NFLD also, and they can do cap. Actually, there are 2 components in this. Nowadays, they measure stiffness and then cap score. Cap score, how much is addition parameter of fat. So highly cap score, highly fat individual. And fibroscan, actually, majority of studies fibroscan on Hep B and Hep C. In fairly few studies have come up, but overall, this data has to be must especially for our patients. Because a lot of our patients still lean, but they may not be high BMI. So what exactly the fibroscan score should be in this patient in population? Still
Because what I am finding is fibroscan hasn't picked up the way I expected it to pick up. It hasn't become, it is still, there is not so much publicity. It hasn't become like a color Doppler or echo of the heart. It hasn't become like a ECG of the liver. It is still being done. People are not doing biopsy. People are not doing fibroscan. So most of the liver patients are being missed.
Is it because of the cost factor or because
I
of
don't know. See, if the demand is there, the cost will go.
is
See,
non-awareness?
Non-awareness.
Not the awareness.
what I am trying to say, if the cost is more, the numbers are high, the cost will go down.
So if there's non-awareness, then the cost doesn't matter because even if it is less expensive and one is not aware, he will not get
I
it.
don't think so. The cost as of today, the introductory cost is 3,000 or 4,000, which is not very high. It is same as that of an echo.
But probably there is non-awareness about this.
Most of the GPs, especially, they don't know that this is available.
And like, how do you recommend that is also not known, like how much reading should be taken normal, so that they are not also
Okay, so the one message which has gone is that it is not necessary for us to go for the not necessary. We need to go for once we have a fatty liver, we need further investigations, another risk factors, simultaneously prevention, and if we anyway we are suspecting NASH, we should go for a biopsy. Okay, we should not hesitate in doing a biopsy for that. Now, when I come back to prevention, quickly, 1, 2, 3, 4, 5.
First thing is that avoid sedentary lifestyles, as sir has told, especially long TV hours watching should be avoided.
No, not eat while watching TV.
I usually don't do it. But still, whenever they're not eating long TV hours, this will be
I see the other way around. My message should be how much exercise per day. Because if I am going to say don't watch TV, then somebody will say I walk every 1 hour, then why are you restricting me for not watching TV? How much walking should be done in children and in adults?
In children, we say that if they are watching TV, we don't allow them for more than 1 hour at one time, and then they should have
They will never be able to see the movie.
break.
Movie
And
is
then
2 hours.
2 hours is the maximum time, but not necessarily that the child is to watch the TV movie every day. So if you're watching TV for an hour a day, and once in a while,
Then why shouldn't I say other way around? Why shouldn't I say other way around? That most of the commercials are a repeat. So in every commercial, you
move and at least deviate the child from the TV.
I'm saying that. So in every commercial, you just get up and walk and come back. Instead of watching the commercial, because the same commercial is going to come again and again. You just go and come back. How do you like it?
I think that's
Every commercial.
Apart from that, I think you wrote it somewhere that every 45 minutes you need to walk for 5 minutes.
That is very fine. So the most important thing is why you are saying don't watch TV. Because when you are watching TV, then you are munching something which is not good for your health. That is the basic.
When you are not
You
exercising,
can't
you
do without it. You can't do without it.
It's impossible in today's world of digital
Watching
era.
TV is okay, but we have to limit the duration of watching TV. There is this habit that mother would normally say that जब तक टीवी देखता है तब तक ये ठीक से खा लेता है, otherwise इसको खिलाना मुश्किल है.
I take it other way around is that it is not TV alone. Because this is also TV nowadays. All the time you are on the WhatsApp and watching the videos. There is no difference between the TV. So therefore you cannot restrict them. If you say don't watch, it is not impossible. But in today's era it is impossible. So we have to give them how to watch TV, how to work on this. So we have to give them and say for example, we say you're seeing on a computer every 20 minutes, for 20 seconds, look at a distance of 20 feet to exercise for your eyes. Similarly, we say that after every 40 minutes of watching, you get up for 40 seconds, walk. Even that limited move, even if small movements makes a difference. So I would say rather is that, I mean, this idea has come to just me just now, that don't watch the commercials again and again. In every commercial, you take a break. When there is a break given in every IPL, when there is a break given to the players, you also take a break. So whenever there is a break, come out.
And at least deviate from the TV, concentration, walking,
So instead of watching 2 movies together, one full and one in the breaks, utilize the break for walking with them. I have started a new thing now. I'm doing it for the last, ever since I had that venous problem and I was worrying that should I walk or not. Now what I have started doing is that every hour I'm walking. So I get up from my home, so I go to my clinic, walking, then for 1 hour I see patients, then midway to Mulchand I walk, then at Mulchand I see my patients, 1 hour I've seen, then I'll walk for 1 kilometer, then catch my car. Then when I reach to IMA, I'll get up half an hour before, half a kilometer before I'll walk. Then in the evening I'll walk till midway to India Gate and take my car is coming back. So wherever I'm getting an opportunity, I'm walking. And I feel that is going to help me coming to you in future.
We already even everybody has to.
It's not, it's nothing to do with order either.
Actually, the sir has pointed it out because no is we have to do the positive things rather than for negative. Saying no is not, but we should tell them what should they do rather than
Absolutely.
this. So first thing is that we should not tell them don't watch TV, don't eat this. We should tell them do the exercise and have.
So
some
one is
time-
walking.
One is walking.
One is walking.
So for
Walk,
adults-
walk and
walk.
whenever you get the time, walk.
And similarly for diet, if you starting don't eat this, that is not be feasible because this in this era you can't say you don't take coke all this thing. You can take with this much calories and this.
Okay, when you're talking about Coke, Moga, I have three things. We have three types of solutions available. We have one solution available is ORS, your field, which is no, I'm not talking about diarrhea at all. I'm talking about there is a solution available. First is water, no calories. Second is ORS, like preparations, with 2 to 3% sugar. Then I have ORSL and all the sports drinks which are 6% sugar, 6 to 8% sugar. And then I have soft drink which are 10 to 12% sugar. Okay. Can I say that either you take water or you take 2 to 3% sugar? Okay. If you are taking ORSL or which is or a sports drink which is 6%, if you are exercising, take 6%. If you are not exercising, dilute it by 50% and take it. And if you want to take a soft drink, if you want to enjoy, fine. But if you are in habit of taking the second one, dilute it to make it either 6% or 3% by water or by soda, so that they will have. So there will be children who will say, I have to take to Coca-Cola. So half of them they can take concentrated.
But I'm sure these children will not take diluted
No, then medically, I'm talking about medically. We are talking about what are the alternatives we are giving them to the family. Instead of saying them don't drink the soft drink, we can tell them to dilute it, make it 3%. 3% still will be the taste. The sugar taste will go down, but other things will still be the taste. So one is that they have to take less of sweet. But my one more thing is, I'll ask googly question to you. Googly, I know. Googly means that 90% people will be wrong in that question. Will be wrong in that question. How much sugar is there in Indian sweet?
Oh, percentage
in Indian.
in Indian sweets, it's honorable that is sugar is syrup.
That's a simple question. See, there are two types of Indian sweet with chasni without chasni. Chasni is 30% sugar and non-chasni is 30% and chasni is 50%. So people, what would they say is, they will sit here and they will eat, they will order for, after eating food, they will eat all types of sweets. And then somebody will say, would you mind taking a Coca-Cola? No, Coca-Cola contains sugar, I will not take. So they will omit 10% sugar, but they will enjoy 30 and 50% sugar. So if I am given a choice between a Rasgulla and a Coke, I will take a Coke. Because that's 10% and Rasgulla is 50%, because the chasni is 50%.
But then they're adding advantage that to squeeze the Rasgulla and avoid the sugar.
Then the purpose of not, then it's not enjoying the
Probably
sugar.
that at least you are getting some proteins and some nutrition.
That's okay.
Coke
So-
is totally.
No. I said when given a choice,
Anyways,
I'm given a choice between a Coca-Cola and a full-fledged Rasmalai, chasni, jalebi. This is what I'm trying to say. Equivalent to amount, then I'm taking much more sugar and we are not aware of that. We don't have a sugar tax. And everybody is talking about a sugar tax in a soft drink. If you need to have a sugar tax, you need to have a sugar tax in all sweets also.
In obese children, what we do is over time following that part, we give the diet modification. I tell them the child has to eat, he has to fill the tummy, but the quality of food has to change. You give more of fiber diet, let the child suffice on feeding and give less of calories in form of less fats and little less sugars, and cutting down on these things, and bargain is that the child will have not more than 2 days in a week soft drinks, not more than 1 day in a week ice cream, not more than 1 day chocolate. So in 7 days he will have 7 different things, one thing a day, not everything every day. And most of these children, when I tell them this plan, they agree to it. The mothers also agree. And the bargain is struck, so the child doesn't trouble the mother कि आज मुझे कोक भी चाहिए, आइसक्रीम भी चाहिए, भैया आज तो आइसक्रीम का डे है, you will get ice cream. Today is your chocolate day, you will get only chocolate. So you may change the day, but in 1 week you will get only one thing in 1 day.
So the message is
Fiber, of course, the fiber.
so the message is the message we've learned is that sugar is a slow poison. Reduce it as much as possible in your diet. So walk, sugar, third. No liver toxic.
Sir, there's no liver toxins.
No. What are the things which are toxic to the liver? Which are the herbs? Which are the medicines? So which are the things people have to say that if they are suspecting a liver disorder? So which are the hepatotoxic? Say there are many herbs which are hepatotoxic.
Paracetamol and aspirin.
Paracetamol.
They have their own.
All painkillers.
But once the fatty liver is established, then next question for drugs. Actually, a lot of drugs are being marketed that they will reduce the fatty liver.
No, we are not.
Or they can further develop. First of all, this thing. But this
So, okay,
drugs means
which
toxic.
are the drugs which are used for fatty liver? No, there are UGCA, which is
Combinations of
they gave metformin, they gave pioglitazone, they gave, then this pentoxifylline, they gave, vitamin E, heavy
These are
dose.
most
These are all
frequently vitamins.
vitamin E.
Vitamin. Rest of drugs they are no much.
I know, but there are, what I mean to say, these are their field. They have to, when they go to them, they prescribe that. My idea is, now the next question is fatty liver reversible?
Fatty liver is definitely reversible once there is a great, well, that depends on stage of liver.
Before NASH.
Before that, it is reversible. If you must modify your diet and if you do exercise and take, suppose you have NASH and take drugs, that
So fatty liver is reversible, and check your triglycerides, try to reduce it to less than 100 or 120. TG can be lowered with drugs, without drugs, chini, chawal, maida, anything refined carb, take it out from your diet. No alcohol, absolutely zero alcohol with a patient with fatty liver, because it can add to early non-alcoholic to alcoholic steatohepatitis, which can cause cirrhosis later on. So therefore, you have to take lifestyle precautions and try to reduce your weight. Even 10% reduction in your weight can substantially reduce complications related to non-alcoholic fatty liver disease. Now, if a person is having fatty liver, can he ever enjoy alcohol? Zero alcohol or 18-20 ml is allowed?
Indian conditions.
Actually, unfortunately, we don't have data for Indian conditions.
No, I don't want to confuse people. Either answer is today, we are not going to wait for the data. What is our recommendation to the people? Either we say, we can't tell the patient, there is no data, therefore you
The
decide.
best thing is that to avoid. But if you have to drink, then less than, for females, less than 20 ml, and for males, up to 30 ml.
Up to 10 gram of alcohol is metabolized in the liver, in a normal liver, and if the liver is damaged, it will not be able to metabolize 10 grams in male and 5 grams in female. So make sure that you calculate the number of grams of alcohol. 1 ml is equivalent to 0.8 grams, and you can see the percentage of alcohol and you can calculate it, how many ml of alcohol is there, convert it into grams. You remember that 10 grams of liver can be metabolized in 1 hour by a normal liver, and here you are dealing with an abnormal liver. Try to reduce it by 50% at least, if you really want to be. But if you really don't want to go to Dr. Ajay Kumar later, that kind of, for consideration of a liver transplant, avoid it with that. Any other thing in lifestyle?
Dr. Ajay, my question here is that apart from drugs, what are the drugs which have to be avoided to prevent further damage of liver? What drugs should be avoided?
Actually, sir, what personally I feel is, well, data which is there, herbal medicines actually which can be liver toxic. Then other drugs depending on the stage of fatty liver. Suppose we talk about PCM, paracetamol. By and large, 2 grams is safe dose. Up to 2 grams daily intake can be there for PCM. And for ATD also, even ATD dose has been started doses, there is no harm.
Why should I even give paracetamol?
If it is required, then we
Short,
need it.
minimum dose, shortest duration.
If it
You
Do
can
NSAIDs
do
also
shortest.
have
All of them have the same effect.
whether paracetamol or ibuprofen or
and all of them have this problem with them.
Mefenamic acid?
See, the trial has come with nimesulide.
And everyone.
Nimesulide is as safe as any other NSAID, but now they say it is 2 weeks. The DCGI has passed Nimesulide for 2 weeks. That means, and we take it for everything else. We can't say that if Nimesulide is for 2 weeks, you can take ibuprofen for more than 2 weeks. So no painkiller for more than 2 weeks, minimum dose, and give it only if required. So therefore, it is important to see, and you know, even one tablet can cause kidney damage also. So therefore, painkillers or painkillers, take them only when necessary, not more than 2 weeks, the minimum dose.
And caution about irrational use of antibiotics, self-medication with antibiotics. I think that's the more very common thing which
antibiotic, and I mean, except for antitubercular, most of the antibiotics will be safe for the liver.
Only thing is augmenting something that was struggling, but that is not very common in this our day-to-day practice. We have not seen an augmentin, which is common drug in West implicated, but we have got very
all the drugs which are metabolized
Very
in the
legal.
liver would be.
Now, what about everybody? Whatever you do, patient will take literature. Whether you like it or not.
Yes.
Because, and specifically all those people who say, he will say, that's what I have fatty liver or I am taking 1 pack of alcohol. They will come back to you, that's what, they will not come back to you how to take care of alcohol. They will say, my SGOT, SGPT is high, how much D52 should I take? So, and D52 is a OTC drug. There is no restriction that it is a drug to be written only on the prescription of an Ayurvedic doctor. To manufacture D52, being a non-OTC drug, no license is required. And to eat D52, you can sell it without a chemist. So it's available to the people, self-prescription also. If I go to Medline, there are more than 60-70 studies which talks about it. It doesn't harm, it may benefit. So would you continue in such cases? I would. I would not. I would say if you believe in Ayurveda, you continue it, but take my medicines also.
Actually, personally, sir, we never stop anybody from taking Ayurvedic medicines. But we tell them because we are not used these drugs, so we can't say whether it will benefit or harm you. So we want to take, that is, we have to discuss with a doctor, physician, what is in long term. And from our side, we advise them whatever drugs are required.
Okay. So in now we come back to the lifestyle prevention is same, whether you have fatty liver grade 1, grade 2 or grade 3. If you develop NASH, if you diagnose with NASH you've done a biopsy and NASH is confirmed, what to do now?
In the NASH, again, sir, the basic diet and test remain same. But the only drug which should be with high dose vitamin E, that is around 800 mg daily, has to be given for 6 to 12 months. And what has been seen, that it decreases inflammation, mainly anti-inflammatory drug, anti-inflammatory. So some degree of reversibility is there, and but it has to be combined in diet and lifestyle both. Alone drug is not beneficial.
So the message is very clear. Normally we talk about vitamin E. We say don't take vitamins in your routine life. You're taking a balanced diet, but no. In India, if you're eating a diet which is liver toxic in terms of fatty liver, you need to take vitamin E. And vitamin E, unfortunately, you need to take it as a supplement, because you will not be able to cover the amount of vitamin E required from the foods or from the vegetables. So vitamin E is another segment which we have learned today. Is take vitamin E 800, that means 400 is the normal dose. Take 800 microgram of vitamin D. Further in NASH.
The other drugs like people do use uric acid, but there's not much of data. But lipid lowering agent, like if indicated, they can be used. They are also helpful to reverse in NASH. Plus,
The pentoxifine.
Pentoxin is actually this.
You do study uric acid too.
Sir, no, one of this. We personally in our this we are not using.
Okay, now we come back. I want to know clinically, can I suspect cirrhosis without a biopsy? Will my SGOT, SGPT help? They can be normal. Is there some ratio of SGOT, SGPT which can help me in diagnosing NASH? Or
the important thing to look for if the bilirubin is raised or albumin is low, they are pointed towards
the time protein becomes low, it becomes a late cirrhosis.
Yeah,
Early cirrhosis.
Early cirrhosis.
Silent early cirrhosis.
That is what it is. Actually, with this biochemical test, they will pick up only 90% liver damage. So we don't have any biomarkers. First, there are multiple biomarkers have come up. People have used in combination, but they mainly for this are fatty liver. First, it was like some fibro test or fibrometer. They have been also used. that may be helpful to diagnose cirrhosis. But they are commercially not available.
But the most what about vaccination? Every fatty liver patient should be on hepatitis B vaccination.
Yes, it should be given and we do anytime.
What about Hep A
Sir,
vaccine?
Hep A vaccine actually in Indian setting, all 90% of children will get.
I am asking my question. If
So-
I have a fatty liver, would I go for a Hep A screening and giving him a vaccine or not? The question is, a person can afford.
If a person can afford, then he can check his antibody titers. If they go, then he
Check the antibody titers, and if it is low, then we should take it.
For Hep A, vaccine.
Hep B can be taken even without.
Sir, actually, we should advise for first HbA1c because high prevalence in India for 4-6%. If they are negative, then only vaccine should be used.
And I go, but
So we
Dr.
should-
Moga, something very new, and that's new is that Hep C is curable. Up till now, Hep C was not curable, and now all over CDC has declared Hep C as a curable disease. 2 new drugs have come. India has launched it, and 12 weeks treatment, and 95 out of 100 Hep C will get cured. And now government is coming out with a plan in specifically in south of Kashmir, where there is an epidemic of Hep C going on, and they're giving free treatment. They have sanctioned something like 100 crores for the drugs. So Hep C, I mean, this is
This was a recent.
recently all over we are talking about that Hep C now is curable, and now we are starting a bingo for HIV. If Hep C is curable, sooner or later HIV will also become curable. So 2 drugs, and I mean the difficult name, both start with S. So
So for the moment, actually 3 drugs have come in the market sir now. First
they're called
drug-
directly acting
DAs.
DAs, directly acting antivirals.
Fourth is now another drug is coming. The first drug was Topsoil.
Yes.
The next comes the Taclastrovir, Ladibazovir. Now fourth is Veltavoir. So all 4 drugs are coming now.
So these are now Hep C is curable. Therefore, every fatty liver patient should go for a screening of Hep B and Hep C.
But so one thing, I will be a bit skeptical also because these studies are from West and with limited number of patients, like 400, 500.
I am only trying to say is, I am giving a good news to the people that Hep C is curable.
Very well. By and large, the response has been good, but study thing is very nice. It's almost curable,
But to
90%.
recommend that any patient who is suspected of fatty liver or diagnosed, he should resort Hep A, Hep B and Hep C all screening.
There should be a screening of Hep B. Go for a Hep B screening. Beside hepatitis B vaccine, go for a Hep A antibodies. If not, take a vaccine. Go for Hep C screening. If positive, get it cured. Because Hep C and fatty liver will be a deadly combination.
Basically, sir, it's been diagnosed by exclusion. We look at fatty liver, we should exclude other causes. So one thing is alcohol. How much alcohol is taken? Suppose somebody is high amount of the alcohol, then will be alcoholic hepatitis. The next is Hep C because genotype rich in India, that can also cause fatty liver. So that's why we do anti-HCV in that.
The India commonest is not NASH. The India commonest is not alcoholic hepatitis. The India commonest is combination of both. People who are having fatty liver as well as they consume alcohol.
Both.
And then diabetic epidemic. So they have 3 factors and that leads to the problem. And then over that they start eating, for every alcohol they take in the morning they start taking paracetamol. So these are multiple factors in India which leads to liver disorder. Now quickly, SGOT, SGPT. SGOT more than SGPT.
So that indicates basically fatty liver, again the ratio is more than 80, but by and large the ratio is more than 2 that indicates.
If the ratio of SGOT versus SGPT, which is AST, ALT in the West, if you have SGOT more than twice of SGPT, it is a alcoholic liver disease. And if the gamma GT is also twice high, it is diagnostic. So you can diagnose. Now if the SGPT is more than SGOT,
Then one has to look for other causes like drugs or in India if it is B or P. So depending on the degree of exam elevation. Normally in fatty liver exams don't go beyond 400 or more than 10 times of a normal. If they are more than 10 times, then one has to look for other causes. Most for drugs.
so we were taught a very clear cut formula. That if the SGOT, SGPT are more than 1000 or more than 25 times the normal. The upper limit is 40, multiplied by 25, it becomes 1000. So SGOT, SGPT more than 1000 means, unless proved otherwise, viral hepatitis A or E, not C, because C is always subacute. Acute hepatitis B sometimes it can cause. B, ischemic hepatitis. Ischemic hepatitis will never come to you. You will go to the hospital because he will be in hypertension. So he will be diagnosed in ICU. Drug induced will always give you history that he is on drugs. So if a person is not on any drugs, and if he is walking on to Dr. Monga's clinic to show it to him, and his SGOT, SGPT is more than 1000, it has to be hepatitis. It has to be hepatitis if it is a child A, if it is an adult E. So without doing any diagnostic test, we can do certain diagnosis.
And
That's it,
OT
that's it,
is
that's it.
double the SGOT is
If it
double
is up to
the-
double, we don't bother. It can be drugs, it can be so many things. But if it is more than 500, then there is a differential diagnosis. These three plus many things will come. And then the fourth which comes nowadays is dengue hepatitis. Dengue. In dengue also sometimes you can get in thousands. The difference between hepatopathy and hepatitis, in hepatopathy is that you have SGOT, SGPT raised with no inflammation, which can happen with so many other conditions. So ignore SGOT, SGPT up to twice the normal, up to thrice get caution. If it is more than 3, start investigating. If it is more than 1000, then the differential diagnosis is only 3. And if the patient is not having fever, then you know. And then in viral hepatitis, there is another formula that jaundice and fever cannot be together. If there is a fever, jaundice cannot be there. When the jaundice comes, fever disappears. But in dengue, both continues together. So if you have fever and jaundice, SGOT, SGPT more than 1000, this is dengue hepatitis. If there is no fever, only jaundice, SGOT, SGPT more than 1000, this is viral hepatitis B or A. ये हमारे GPs के formulas हैं. In malaria, it will never cross 1000. It will be 400, 500 up to. In malarial hepatopathy, SGOT, SGPT will be up to 400, 500. So these are the messages you should write today and send it to all your CGP members. That tricks and trade in managing patients with liver disorder. That's your, send it to all GPs, tricks and trade. So anything else? What about LFOS?
The LFOS will be raised because there is a story of fat. In fatty liver will be raised, but usually elevation is less than 5 times. And if they are more than that, then one has to look for the
Isolated increase in LFOS, should I investigate?
isolated
It can be bone, it can be liver, it can be.
It can come from multiple sources. First and foremost thing is that check whether sample is fasting or not. Because suppose you're not being sampled in fasting, it will be elevated. Then
So that's an important message. I was not aware of it. That, alkaline phosphatase, if patient is not fasting, can be raised. So make sure that you ask the person that LFOS is done on a fasting or not. Because normally we say LFT, fasting is not required. So that's a learning for me today. Next.
Then next comes physiological information like children's pregnancy, we will expect to raise this thing. Then third thing is
What about vitamin D? Because everybody is vitamin D deficient.
that can be bones. Underlying bone is mostly this osteomalacia.
What about isolated gamma GT? Because we were told that if this isolated gamma GT with normal SGOT, SGPT, don't touch. Just watch.
That's what. Actually, suppose there are other liver enzymes are normal, then we don't get this follow it, and we just go do ultrasound, do not biliary obstruction. If there is no biliary obstruction and only this much is raised, then we just advise them to follow.
I have a patient with fatty liver. If ultrasound shows grade 1 or grade 2 or grade 3, how often should I repeat ultrasound? Do I need to repeat or how often should I repeat?
So repeating ultrasound is not useful in these patients. If at all, once in a year is good enough for that. That too just for screening purpose. If more than 40 years to pick up tumors, because studies have shown even in NFLD, malignancies can develop cancers.
So do I need to do alpha beta protein in such cases?
Sir, ultrasound is best because AFP has a low sensitivity. So if you want to do ultrasound, that too again after 40 years of the age in the males and for females 50 years.
What about SGOT, SGPT in pregnancy? Fatty liver in pregnancy?
So,
Pregnancy and fatty liver. And pregnancy
Sir,
and pregnancy-induced hepatitis.
sir, in India actually pregnant with fatty liver has never been seen per se. Majority of patients who come with this enzyme, either they were achieved if they more than 10 times, or it is like your pregnant cholestasis. These are two patients which we see most frequently. Fatty liver per se actually we
Normally they say happy is absolutely dangerous in pregnancy.
in pregnancy, actually if you look at recent study published from the AIMS, what they have shown is pregnant patient may have more risk of developing acute liver failure, but the mortality with once developed ALF is same as that of non-pregnant patients. So they have increased risk of developing ALF. That's true.
Dr. Tandon is doing a surgery and patient has a grade 3 fatty liver. Should he go ahead? Should he?
Actually, if his liver enzymes are more than 5 times, then surgery should be avoided because in this patient there will be decomposition. Look for the and if the enzymes are not more than 5 times, then surgery can be necessary. Provided function normal also. Because in fatty liver,
No, sorry, I was on the phone at this time. You're saying it's 5 times or 2 times? Sorry.
so actually 3 to 5 times, but most of 3 to 5, not
3. So let's define 3. So more than less than 3, let him treat. More than 3, he needs a clearance from you. Because
Actually,
5 is a little bit more. So apart from anesthetists, he needs a clearance from a gastroenterologist or a physician. So 3 is the limit. Normally 2 we say more than 2. I normally would manage. I normally say a GP should manage a SGOT, SGPT rise up to 2 times. A physician should manage up to 3, and more than 3 you should refer it to a gastroenterologist. More than 3 times you should refer. Same thing is there.
More than 10 again, you will go to a GP. More than 10 again, go to a GP.
More than 10 times.
10 times.
So that's not that's a hepatitis. That's not. And same thing is there for a kidney. More than 60 GFR that the GP manage, 30 to 60 that the MD manage, less than 30 the GFR or the DM should manage. So this is how we are now creating 30, 60, 90. 60.
60, 30 and less than 30.
Normally we say 30. More than 30, less than 30. More than 30, physician can manage. A good GP who is a good physician can also manage more than 30.
4 or 5 goes to the
4, 5, difficult to remember. Remember the number, 30, 60, 30. Similarly, we define it 2 times normal, it's easier, 3 times normal. 2 times normal GP, 3 times normal MD, more than 3 times scientific. So that everybody shares and they take over the responsibility for the whole thing.
And another thing is, sir, if you are doing LA, then that doesn't matter much. Only when you are doing a G or spinal, then the things will come for giving especially. So
How many times in such patients the prothrombin time should be done?
so PT only once.
But before that, before that,
Right.
I'll come back. When do we do for serum proteins, serum albumin, and when do we do Pidgeotide?
Actually,
So they are all progressive methods. So they all are.
actually, if we look at overall, so studies have, whatever data are trying to show me in patients who are asymptomatic, even doing routine LFT is not helpful. But what studies have shown is only when the risk factor they have shown me routine LFT may be done. But if you are aware patient underlying liver disease, then baseline LFT includes your enzymes, PT and protein, and all things has to be done.
I'm on an important point.
That is very important. Our concern is most of the times when we are dealing with the polycystitis. At that time, if you put some gallstones, that is the enzymes are ranging even up to 203. And the PT may not be given. They may not. So what should be the protocol? Whether we should go ahead for surgery if the enzymes are raised?
If the polycystitis, most of the time is because of obstruction, which is there, because stone in the neck and some obstruction bile duct and some So in this setting, I think we are most of the time we will operate. So it depends upon what disease the patient has and what thing has come.
What I do is everybody.
urgent surgery.
I will now at an urgent meeting at the Bhavan with the Ministry of Health on cancer prevention. So I am requesting now Dr. Monga to take over further discussions, and we'll come back next year. Next Thursday, I may not be here for the session. We will have a session on pediatric nephrology and pediatric kidney and pediatric urology, and that will be done by Dr. V.K. Monga and Dr. Arakan in my absence. So let's continue with our team. Please come in.
So somebody who needs an emergency surgery, then these things become immaterial. Suppose we are doing elective surgery, then investigate. So depending upon the treatment, then also one has to decide.
No, because now the surgery in acute polycystitis
Is very common. So that's where we go into
very common.
This is kind of good to operate.
Day in and day out to be taken.
So it depends upon the clinical scenario the patient is coming. Suppose somebody has obstruction, then you operate with them.
Obstructive thing is altogether different. But without obstructive CV is common and
Then it is
quite high, significantly 300 and 400. So in those cases there is some time problem whether to operate or whether not. That becomes surgery.
Suppose person doesn't have got a history of blood transfusion surgery, his circulant is negative. FC later he will go into surgery. No type of surgery is only.
Dr. Vasdev, in your practice also you must be seeing ladies come with their children. Liver check करो ये इसका वजन नहीं बढ़ रहा है, ये his height is not increasing, his weight is not increasing, he is not doing well, he is not eating well. How much do you blame the liver for all these things in children?
Yeah, I think most of the time when they have gone to mostly RMPs or old ladies, somebody might have fed into their mind that बच्चे का liver ठीक नहीं है इसलिए he is not eating well. While the reasons may be multiple and different. And once we see that if they get an ultrasound, the liver looks normal, the enzymes are normal, and it's the liver which is unnecessarily blamed. The child may not be eating well for other reasons. If he has got some infections, in which commonest infections are viral, which are short-lived, or sometimes bacterial, in which urinary tract infections are very common, and they are missed because there are no clear-cut symptoms. The child may just not be gaining weight, he may be lethargic, he may be anemic, and he may have mild fever, he may not have urinary symptoms. So sometimes these are missed and the child is not eating.
Or a worm infestation.
Worm infestation. And other thing that the child is very choosy about the diet. I ask them कि ये अपनी पसंद की चीज़ खा लेता है, कहते हैं आप बाहर जाता है तो सब कुछ खाता है, तो वो घर में नहीं खाता. किसी और के घर में जाता है then also he eats well, but he doesn't. Maybe the appetite is good. Then I tell the mother that you have to change the formula of your preparation. Maybe some variety is needed. These children, unlike what we used to have, that जो भी घर में बना है we have to eat it. They have large variety and they have a large choice. So they sometimes get pampered, they sometimes get also spoiled and नखरे करते हैं. दूसरे के घर में खा लेंगे, स्कूल में खा लेंगे, बाहर खा लेंगे, लेकिन अपने घर में नहीं खाएंगे. So we have to really see what I see objectively कि बच्चे की height weight अपने एज के हिसाब से ठीक है कि नहीं. Sometimes the mothers are not happy. Recently I got a child who was 2 years old, जो कि normal weight उसका 12 kg होना चाहिए average weight. This child was weighing 18 kilos. And he was having humps of fat all over and a bull neck, and there was hump on the cheeks, and cheeks were rounded with long hair. And I was wondering what's wrong. Something is wrong with the mother rather than the child. And she is not satisfied. She came that he khata nahi hai kuch. Then I told her that he is already obese. He is on the overside of weight, 18 kg, and itna fat chal raha hai. So then the husband quietly came to me later on. And he said, Doctor, you are the 4th doctor I am taking her to. इसकी यही complaint है, जबकि बच्चा हमारा overweight हुआ है. So it's sometimes difficult to convince the mothers that actually the child is eating well, growing well. It may not be to the mother's satisfaction, but objectively we have to see.
So mother needs psychotherapy.
Psychotherapy, and sometimes they are overestimating that ये बच्चा हर वक्त खाता ही है. Especially those mothers who are non-working, they are homemakers. सारा दिन वो एक ही बच्चा होता है, उसके पीछे पड़ी रहती है, खाता रहे. And children tend to get they are rejecting food because they are retaliating. And when you talk to child 5 साल वाला, वो भी तो हर वक्त कहती खाते रहो. So retaliation हो जाती है food के लिए. They start disliking food, and otherwise because they are never allowed to be hungry. So objective देखना है कि growth ठीक है, height weight ठीक बढ़ रहा है, then there is something wrong with the mother's thinking. But yes,
So when do you believe, when do you start thinking that this patient of fatty liver may grow or may not grow into cirrhosis? Any markers or any indications you have?
Actually, if his BMI is very high, more than 30, if TG are gross elevated, enzymes are raised, then high probability of developing cirrhosis will be there. And if continuously overweight and this thing, then he can progression liver disease will be there. So once patient has come to you with a baseline, then we advise them for this and then follow. So over a period of time, then we can decide.
So even to, let it not progress to cirrhosis, same precautions are to be taken, for example, decrease in weight, BMI, diabetes.
Cornerstones or NFLD, unfortunately, it is same, diet and exercise. Lot of drugs have come at drugs. People do come to us, give us some drugs, but we tell them drugs is not a solution. Solution remains same, diet and exercise.
And that's like chilling and
Actually, there's no. Lot of drugs have come, but there is no longer drugs. We have to, there is patient psychology, actually psychology of all of us to find an easy solution. So easy solution is to take one pill and have solution for that, rather than cutting your food intake and doing exercise. That is tough. So everybody tries to find an easy way out, but unfortunately, there is no easy way out.
there are a number of companies marketing their products and they are selling like anything.
I think they are cashing on the psychology of the patient. That they want drugs, and most of the time if you don't write medication, they feel that they have paid the consultation and they have not got any medication, so they don't feel satisfied.
Only except the view that it is to be
It's
delivered.
like writing UDC. Most of even gastroenterologists like UDC because patients want it. Ultimately, they want something has to be. Even if you justify to them, they will not be satisfied. They do some other third, fourth people.
Including the HAPA type of items.
So there is no rule.
Even they would, any would,
Actually, I will like from you this thing, from your perspective that you just pass the message across the board that most important diet and exercise. If at all some patient wants drugs, then they should drug will not help you. We may diet for satisfaction, but this will bury a hole in the pocket.
so there is no shortcut.
No shortcut.
To fatty liver, it has to be real exercise and
Because if some
minimum
medication has to be returned that the patient is not satisfied, what is the safest and the best which we can give without harming the patient and without harming the liver? It will not do good, but it should not harm.
I think UDC is the safest out of all of it because UDC is a normal biological present in our circulation. So it is not very severe side effects having mainly it can cause some diarrhea only. And that's safest.
Similar on like
So actually all of these are only Ayurvedic preparation. Sliver is also that.
Sliver is also
a lot of
Ayurvedic.
Most of the drugs which are available for liver, they are all phytomedicines. Phytomedicine is known as a word, so they are all phytomedicine, nothing is from our side.
Or any multivitamin would be of any use.
Actually, take one fresh apple or fruit which is coming the season that will you 10 times more.
Any role of zinc, because zinc has been talked a lot about in every illness, all gastrointestinal illnesses, whether it's diarrhea, immunity, respiratory, or any illness, and then zinc is related and zinc deficiency. So any role of zinc in
Zinc has, people have tried but there is no benefit from giving zinc.
But there are good trials of zinc in diarrhea.
diarrhea? Yes.
Even for WHO and
WHO
recommends to give zinc based oils or zinc therapy as such.
So
Separate.
diarrhea and October, even for low immunity, they say that zinc deficiency can
Cause
cause low immunity. Then thirdly, children who have got recurrent respiratory infections, again it is attributed sometimes to zinc deficiency. And if we test zinc, probably most of our children will be deficient in zinc. And I don't know whether that deficiency can actually convert into an illness or it is only deficiency alone. Like we see vitamin D deficiency, almost everybody who's
Everybody has that.
So that has become a big problem now. Everybody is using vitamin D and
And we are getting hypervitamin doses being children, overdoses, because they go for pain. It's such a common phenomenon in children कि बच्चों के पैरों में दर्द होता है, शाम को आता है, टांगों में दर्द बहुत होता है. They'll go to a general practitioner, he'll write calcium and vitamin D. Late he go up, they go to orthopedician, he'll write calcium and vitamin D. And then they might go to a pediatrician, he'll also write calcium, vitamin D. So in that course of 3 months, the child will get 6 lakhs plus 6 lakhs plus 6, 18 lakhs unit of vitamin D. And then he comes with even more severe bony pain. We do a calcium level which is skyrocketing to 15 or 16. The vitamin D level is to 400, 1 to 400. So he's got hypervitaminosis D rather than under vitamin.
And how do you blame deficiency of vitamin D causing all this pain? Some people say it's bullshit.
In children, these are called as growing pains, and these are very normal, especially in boys of the age of 6, 7, 8 years. They are very active, they play a lot in the evening. Typically, they'll come back home and then they start talking about leg pains. And the simple solution I tell mothers is कि थोड़ा सा leg raise करके रखें 5-10 मिनट, give a little massage on the leg, and the child is quiet. It's only that because of excessive playing, sometimes there's pooling of the blood, and after a little massage they get relief. And this pain continues for few months to years, and these are growing pains, bony pains, but doesn't merit medication. Unless they are very severe, we give them a dose of paracetamol if the child is not able to sleep because of the pains. Otherwise, it's not related to vitamin deficiency or calcium deficiency. and the mothers will always be after us, calcium की कमी तो नहीं है, देख लीजिए. When we do the calcium level, the umpteen number of times, and it's all normal just to satisfy them. We know that it's not because of deficiency. These are normal growing pains.
And Dr. J, in fatty liver, what are the typical manifestations a patient will come to you and you are suspecting fatty liver?
Actually, majority of the patients are asymptomatic, and main symptom is it was some pain like right upper quadrant was enlarged liver. So majority of patients are coming because of swimming, like they have gone for some test and ultrasound has been done, and that is what fatty liver. So majority of patients are asymptomatic with fatty liver until they develop cirrhosis in later stages. So most of patients who are coming are more asymptomatic, or they may have got some obesity and they get ultrasound done condition fatty liver. What I will say is that the fatty liver, even if it look, the mortality caused still in them is cardiovascular stroke and cancer. So fat in the liver do cause cancer, but still it is not a leading cause of death. The leading cause of death in this population still is heart disease, or stroke and cancers. So the fatty liver indicates fat excess is not in the liver but everywhere. Everywhere, heart, blood vessels. So you have to, and leading cause of death is cardiac. So they have to wait for other factors, that is for liver reason.
We are only bothered about liver. In fact, when they are reporting fatty liver, they are also mentioning fat deposits in spleen and fat deposits in kidney also, which is overlooked by everybody, because the final conclusion is like grade 1 fatty liver. And almost every ultrasound you find fatty liver. And when you see all the report, then you will see you have got fat all over. Your whole body is showing
In fact,
fat.
Dr. Jonas, I must say that till around 2, 3, 4 years back, every GP will pass it on like this. Okay, fatty liver doesn't mean anything.
Right.
But nowadays, people have started thinking about it and working on these issues.
Maybe there is a red flag.
Yeah.
You start with, and then before the damage is
Before
irreversible.
damage is much more.
This is the precautions that to be taken at the first level itself.
That is what is important. Now you understand the reason behind the fatty liver, so you have to explain. Instead going into the failure and services, you better change your habits and go back to the norm.
Yeah, I think that was ignorance on our
Ignorance,
part,
our
that we were overlooking the report and I see what the mind knows. Even if I am reading fatty liver and I don't know the implication of it, I will just pass it on as normal. But now we know the implications, and this may be a starting point where these things can cascade to more ominous and grievous things. So this can be taken as a red flag and start acting on it.
But the only thing is that action has to be from patient side, and the only thing is that I can exercise, and which nobody is ready to accept. That is what is the
From
biggest
our side,
issue is that.
we explain to them, let them the correct advice. Now it is up to patient to follow or not follow. At least we are not faltering and giving the correct path. They may not tread on the correct path, but then we are showing them the right path.
Now you must be seeing even people of 30s, early 30s, they're coming with cardiac problem, MI, strokes.
Yes, they are.
So this is a fact. This is a fact. Here also fact. So in 40 years you are getting cardiac illnesses.
Any role of smoking in these no direct relation?
Smoking doesn't cause fat, but it increases the risk of cardiac disease. Like it will consider you have high stroke, cardiac events, and in this side it's a cancer of liver, but mainly cardiac and stroke events go like anything else. So they have to be able to smoking also.
That's why cirrhosis is increasing,
Yeah,
because
this
it's
is-
smoking and the fat flowing in your vessels. That
Exercise you have already told, in diet what will be your 1, 2, 3, 4, 5.
And in diet we advise them, we take what is with ideal body weight, not what weight that coming like what for this height is much is body weight, and then we take how much calories. We have to make slightly deficient. So we by formula just we make 25 kilocalories and low fat. That means total out of total calories less than 20% should come only fat. We take
500 calories are good enough.
No, sir, only 20, we take 25 kilograms per kg body weight. Suppose somebody got height of 5 feet 4 inch, then he should take around like 12 kilograms, that is 2.4 inch. So according to his weight, what is ideal weight should be that. And total calories, only 20% should be of fat. So we take help of dietitian, we make some rough chart, but we do dietitian know the dilemmas.
Sugars also,
Sugars are total carbon 60% there, refined sugar less than 5%.
refined
Less
sugar.
than 5% even there.
So cutting on fat, cutting on refined sugars, and anything else which
And that's an increase of PUFA content, PUFA in this form. This is helpful.
and more of fiber.
more of fibers. That carbohydrate covers them.
The best diet for Kufa and Kufa.
What I have seen on it, they advise to use multiple oils.
That is what is very important. That mustard oil, even desi ghee plus olive oil.
All things should be taken.
Everything should be taken.
So should it be like our dietitian told us that एक महीने आप mustard oil use
हाँ,
करो,
that-
एक
that
महीने
is
olive
right.
oil use करो, एक महीने देसी घी use करो,
That is the
एक
ideal
महीने
actually.
groundnut use करो, एक दिन एक महीना सफोला use करो. So automatically
rotation
6
वगैरह.
months there will be rotation.
Yeah, but why not to mix everything every day? Because every oil is giving you different thing. Not
Well,
the
let's
same.
say you have to buy everything and stock
Actually
it.
costly रहेगा, so scheme patiently costly रहेगा. Suppose this to buy 6 oils, so his budget like 4 is 5,000. So he will not take.
Not 6 oil, at least 3 oils everybody is eating.
हाँ,
Desi
ठीक है.
ghee and mustard oil and olive oil, otherwise rice bran and sunflower oil.
और एक महीने के 3 ऑयल ले लें,
हाँ.
अगले 3 महीने में दूसरे 3 ऑयल ले लें.
Because the most important thing, everybody is trying to avoid desi ghee. Desi ghee is the worst thing for the health, which is probably not true.
Not right.
Actually, which is not true. So that this should disappear from the mind of doctors first, and then from the general public. Because every time you say that no to desi ghee, that is not.
I think with this, we close our discussion for the day. And we are thankful to Dr. Lekma from New Plant Hospital and Dr. A.S. Vasudeva, integrating nephrologist, for being here with us today. And Dr. Tandon, of course, is your own finance secretary of IML. And Dr. K.K. Agarwal was, as usual, giving us full information and full knowledge. And we will again meet you next Thursday at the same time, 3 p.m. Thank you very much.